Good evening, everyone. We welcome you all to the 7th session of Ophthalmology PG Classroom. Today, we'll be having another interesting case-based discussion, which is from Alappuzha Medical College. Often in exams, we do get cases which is a mixture of different subspecialties. And today we are having one of those. It's a combination of oculoplasty and retina. And to discuss, we have here expert faculty, and Gopal sir will be introducing the faculty. Over to sir.
Thank you very much, Dr. Hena. This is the 7th edition, as we said. We are alternating between a case presentation discussion on one week and an investigation-based chart review or something like that in the next week. So last week we had corneal topography part 1, and today we are having this case presentation from Alappuzha Medical College, which will be discussed by Dr. Mallika OU, Professor and HOD of Ophthalmology of Alappuzha Medical College. And oculoplasty specialist that we are having today is Dr. Marian Pauly, who is head of oculoplasty service at Giridhar Eye Institute. We have Dr. Dalia, who is the associate professor of ophthalmology at Alappuzha Medical College. And there is a retinal side as well, which will be discussed by none other than our vibrant Dr. Mahesh G, the head of retinal services at Giridhar Eye Institute. So we have expert faculty today, and over to the case presentation by Arati Menon. Without wasting any time, let us start the presentation.
Good evening all. So I'm presenting a case of Surendran, 65-year-old male. History of presenting complaints. Patient was apparently normal 6 months back. Then he complains of swelling of right upper eyelid, which is insidious in onset. And gradually progressive swelling. Initially, it was small in size and gradually increased to the present size. No history of rapid increase in size, not associated with pain, redness, or in ulceration. No history of blurred vision, no history of watering, no history of foreign body sensation.
Okay, Arati, continue.
In past history of swelling over right lower lid 2 times. It was associated with pain and resolved spontaneously within 1 week. And there is history of defective vision in left eye in 2013, which was insidious in onset and went to nearby hospital for that. They told that there is blood within the eye and underwent surgery for the same. Patient was told that some oil was put in left eye. Later, after 2.5 months, second surgery done to remove that oil along with cataract surgery. Patient says there was no improvement in his vision after surgery. A history of systemic hypertension and he's on treatment for 20 years. History of coronary artery disease on treatment for 20 years. No history of diabetes mellitus or CVA. No history of prior radiation therapy. No history of other visceral cancers or skin cancer. No history of immunosuppression. No history of poor wound healing. No history of coagulation disorders. Then personal history. Normal appetite, mixed diet, normal sleep, normal bowel and bladder habits, no history of smoking or alcohol intake, family history, no similar complaints among family members, socio-economic status, middle class, socio-economic status. General examination.
So, Arati, you stop. So, what is your impression from the history? You take the history. Patient has, you just summarize the history.
So, patient was apparently normal 6 months back, then complains of swelling over right upper eyelid for the past 6 months, and which was insidious in onset and gradually progressive, not associated with any pain or ulceration, no rapid increase.
Stop. So, what is the history of a rapid increase in the size, and what is the significance of associated pain, redness, or ulceration?
The swelling can be benign or malignant. So, history of rapid increase in size suggestive of more towards malignant swelling, and associated with pain, redness, or ulceration, signs of any inflammation associated with swelling. with pain can be perineural invasion associated with any malignancies. So to rule out
So what about this blurred vision?
blurred vision, a large swelling which press upon cornea can induce astigmatism and patient can present with blurred vision.
Now, what type of astigmatism it produces? Usually
Irregular astigmatism.
upper eyelid pressing more.
What type?
What type of astigmatism?
With the rule
With the rule astigmatism.
astigmatism.
What is the significance of this watering foreign body sensation?
Watering foreign body sensation. If it's a malignant tumor, it can be associated with trichiasis or eyelid distortion, which can produce watering foreign body sensation, or it arises from the meibomian gland. It can obstruct the meibomian gland orifices and can cause evaporative dry eye-like symptoms, watering foreign body sensation.
Okay. The next slide. So what is the significance of a history of recurrent episodes? What all things you have to think about when the patient says such a patient with such a big swelling presenting with recurrent episodes of
Recurrent at the same site can should be suspicious about malignancy.
but
and
this
other
patient is in the lower lid, not in the
Right.
upper lid, isn't it?
other spread of tumor or spread of tumor. If it's malignant tumor, it can be around lower lid also.
Why in the lower lid? What is the reason?
Spread to
Okay.
How will it spread?
pegyctoid spread for sebaceous gland for carcinoma like sebaceous gland carcinoma. There is pegyctoid spread which through the epithelium into the conjunctiva or through the lip.
Or any other reason for multiple swellings?
Other than spreading from the same one.
Some syndromes can cause multiple site of carcinomas, like multiple, in case of basal cell carcinoma, multiple BCC will be there in Muir-Torre syndrome. Golden.
Any other, what about this multicentric origin?
So due to the multicentric origin of sebaceous gland carcinoma.
That is very important. Sebaceous gland, when you think about it, adnexal tumor, sebaceous gland carcinoma is one common thing. Why it is common? Why we are saying sebaceous gland carcinoma common?
It's common in Asian population, in India. Most common tumor of eyelid, most common malignancy of eyelid.
So multiple tumors, we have to think about a multicentric origin rather than a pegyctoid spread. Pegyctoid spread presents like what? Is it like a mass or anything else?
Squamous cell carcinoma in situ.
No, pegyctoid spread in sebaceous gland carcinoma presentation is like this or any other type?
Conjunctivitis.
Yeah, it is like a blepharoconjunctivitis or blepharitis. Rather than a swelling, patient presents with a blepharoconjunctivitis like picture or watering foreign body sensation like that. Okay, let's continue. So this patient gives history of defective vision in left eye in 2030. According to his statement, it was sudden onset or insidious onset.
Serious in onset.
Okay, and some blood within the eye. Is there any history of erythropsia-like symptom? Is it like erythropsia-like? No. From the doctor's statement, he may be saying some blood in the eye. Okay, continue. So what is the next slide? So again, you have written, so many, no history of prior radiation therapy. What is the significance of this?
Prior radiation therapy mainly to the head and neck region, which can cause predispose to the malignancy of eyelid.
Which type of malignancy?
Mainly basal cell or sebaceous gland carcinoma.
Then visceral cancers or skin cancers again.
Visceral cancers can be associated with eyelid malignancy in some syndromes like Muir-Torre syndrome, then Bate syndrome, and skin cancer. Skin conditions also associated with eyelid malignancies.
Which malignancy? The skin conditions associated mainly with which type of malignancy?
Mainly with the basal cell carcinoma.
With the basal cell carcinoma. Okay, what skin diseases? What are the common skin diseases?
Commonly xeroderma pigmentosa.
Yeah, xeroderma pigmentosum. We have seen case xeroderma pigmentosum with the basal cell carcinoma. Other associations, skin,
Other skin association.
other than xeroderma pigmentosa. What about sun in
Sun exposure,
what is
like
that?
actinic keratosis.
Actinic keratosis, actinic keratosis. So that is the importance of occupation. Okay, then history of immunosuppression. What is the significance of that?
Also predisposes to eyelid malignancies like HIV or any kind of medication like steroids, long steroids.
HIV, which malignancy? You can say specifically HIV
Kaposi's are like BC,
Yeah.
Kaposian.
So what is the presentation Kaposi's usually? As lid malignancy or something else? Harsha? Yeah, angioma like in the lid or even subconjunctival hemorrhage can present as a subconjunctival hemorrhage. Okay, then you have written poor wound healing and history of no history of coagulation disorders. What is the significance of that?
Mainly for the post-surgical healing. If it requires a lid reconstruction, it's just like a prior pre-op investigation, pre-op history, just to note the healing capacity.
Okay, continue.
I think in the history, you can ask for history of previous surgery for the swelling end also. That also can go for poor wound healing.
Then personal history, normal appetite, mixed diet, normal sleep.
Okay, continue with the examination.
General examination. Patient is conscious, oriented, moderately built and adequately nourished. No pallor, icterus, cyanosis, clubbing, pedal edema or regional lymphadenopathy. Skin, hair, nail normal. Vital signs, pulse rate is 90 per minute.
Which are lymph nodes you have looked? That also you can mention.
It is preauricular lymph nodes and submandibular lymph nodes.
The drainage area.
Canthal lesions and medial side lesions, you should look for preauricular lymph nodes and lateral side of eyelid. Mainly lateral 2/3 of upper eyelid and lateral 1/3 of lower eyelid.
But it is the reverse you are saying.
What?
It is the reverse. You said medial canthus to submandibular, not preauricular. Preauricular is lateral. Okay, continue.
BP is 130-80 millimeter mercury and patient is afebrile. Systemic examination, respiratory system, normal vesicular breath sounds heard, no added sounds. Per abdomen, no hepatosplenomegaly noted, no palpable mass, no paraiotic lymph nodes noted. Central nervous system, higher mental functions normal, cranial nerves 2, 3, 4, 6 dealt in ocular examination, other cranial nerves normal, motor and sensory system within normal limits, no cerebellar signs. Cardiovascular system, S1, S2 heard, normal, no murmur, musculoskeletal system within normal limits. In going for ocular examination, head posture normal, no facial asymmetry except large swelling over right upper eyelid with mechanical ptosis. Ductions and versions are full on both eye. Left eye there is 15-degree exophoria. Then visual acuity. Vision in right eye 636 with pinhole improving to 680 and color vision is normal. Left eye vision is PN plus and PR is inaccurate, that is only in the temporal quadrant. Can I proceed, ma'am?
Yeah, proceed.
And adnexa, right eye. Right eye lid and adnexas, there is a swelling of size 15 into 15 millimeter in the upper eyelid with well-defined borders, and it is immobile, bosilated surface, which is firm to hard in consistency, involving anterior lid margin. There is widening of anterior lid margin, but no thickening of anterior lid margin, and there is no loss of eyelashes, no rounding of posterior lid margin, and there is dilated veins over the swelling. Skin over the swelling is mobile, no signs of any ulceration, no signs of trichiasis. The mechanical ptosis present with upper lid covering half of the pupil, lower lid normal, no swellings noted.
So what is you can repeat why these signs are important. You mentioned about widening of the anterior lid margin present, but there is no thickening of the lid margin. Again, back to our discussion, what is the significance of all these?
Widening lid margin and thickening with the loss of eyelashes, rounding of posterior lid margin, all these look for all these malignant lesions can present with all these signs. And there is dilated veins over the swelling also for malignancy.
Okay. Continue.
Conjunctiva. Palpebral conjunctival surface of swelling shows yellowish discoloration. This is the picture showing palpebral side. And bulbar conjunctiva is normal. There is no congestion or no mass noted. The cornea is clear. Anterior chamber normal in depth, that is Panther is grade 3, and it is quiet. No anterior chamber reaction. Iris normal in color and pattern. Pupil 3 millimeter round. Direct reaction is brisk and consensual is sluggish. Lens nuclear sclerosis grade 1. Early lens opacity present and peripheral cortical opacity is also present. Fundus examination of right eye. Media slightly hazy due to lens opacity. Disc normal in size and shape with well-defined margins. Cut disc ratio is 0.4. Neuroretinal rim is pink with ISNP rule obeyed. Arteriovenous ratio is 2:3. Foveal reflex is present. Macula normal. With indirect ophthalmoscope, no signs of peripheral retinal degenerations noted. Going for examination of left eye. Left eye, lid and adnexal normal. Conjunctiva also normal. Cornea, diffusely arranged pigments in endothelium. Anterior chamber, irregular in depth, especially in periphery due to peripheral anterior synechiae, and no AC reaction noted. Lid and adnexa. Left eye, iris, broad-based peripheral anterior synechiae extending from 1 o'clock to 2 o'clock, extending around 1 millimeter into cornea, associated with small linear opacity in cornea, and also other PAS in 10 o'clock to 11 o'clock position and 8 o'clock position associated with corneal opacity. No signs of iris atrophy, no signs of any neovascularization iris. Pupil is 5 millimeter and it is irregular. Direct reaction is sluggish. Consensual is also sluggish. Lens status aphakia. Next is fundus examination of left eye. Media is, pupil is 6 millimeter. A concave smooth elevation of retina is seen extending from 3 to 9 o'clock position, involving disc and macula, suggestive of tractional retinal detachment with macula off. Retina appears to be thinned out. There is linear white areas beneath the surface of retinal detachment and all 4 quadrants suggestive of subretinal bands. So this is the picture of fundus of left eye. And there is rigid full thickness fixed puckering of retina suggestive of star-shaped retinal folds in the superior quadrant, 3 o'clock hours, suggestive of grade C, that is P, and also P, PVR changes. Pigmentary abnormalities present in all 4 quadrants. Retinal break of size, 7 disc diameter, around 4 disc diameter away from disc in superior quadrant, and then underlying choroid is visible. Anterior margin of this retinal break has pigmentary abnormalities. Another retinal break of 3 disc diameter in the inferonasal quadrant. So this is about
why did you say it is tractional detachment? When there is a break in the retina, what detachment is that?
When there is a break, it is a rhegmatogenous.
There is a big break, no? There is a big break. You said 6 disc diameter. Where is the traction?
Traction, the appearance was concave smooth elevation.
Concave, is it concave? It is convex, no? It is coming towards, it is convex. It is into the vitreous. It is convex. there is a big break that you can clearly see, then
Yes.
why are you telling tractional detachment?
I said I was thinking of more towards tractional RB.
What is rhegmatogenous retinal detachment?
Rhegmatogenous retinal detachment is due to break, which
Then what do you see here?
there is break. So
Then what is it? It is a where is the traction? And you said there is silicone oil.
sir, from the history,
What you can see anything in the examination?
no, sir.
No, you can't see. Okay, okay. So these are all basic things. No, when there is a break, it has to be rhegmatogenous detachment. Where is the traction coming here? And that too, it's a vitrectomized dye, right?
It took me right, sir.
Vitrectomized dye, where is the traction when you remove the vitreous? Don't mistake, I mean, simple clinical findings don't unnecessarily tell the traction and all. It's very obvious. It is glaring at you.
Yes, sir.
The problem is you try to extrapolate by imagination. Just see, tell what is seen. Okay.
Just to talk from the side of the presenter.
Yeah.
Is the regma the cause of the retinal detachment, or
We
is
don't know.
traction the cause of the regma? Not to Mahesh, not to you.
No,
Is the
based on
regma the cause
findings,
of this detachment, or is the traction the cause of the regma?
Thinking of, sir. First, traction appeared, then later it post.
Or is the break secondary? That is what
And
is
to the tractional detachment. That was my sorry, sir.
Which
what is the
happened first?
commonest? This is what could have been the primary pathology in the left eye?
Patient said there is an insidious onset of blurring of vision and blood within the eye. So I thought there might be a vascular occlusion because of
Vascular occlusion.
hypertension.
Vascular occlusion, even you can get in a rhegmatogenous detachment, when suddenly there is PVD, you can get bleeding, right? Vitreous hemorrhage. That also can be similar.
Yes, yes.
So it can be, what you can just say is now there is severe PVR with a large break. Probably silicone oil is there that you can make out clinically. So that's all. Other unnecessary words can be avoided to be okay. Yeah.
Okay, Ardi, continue.
IUP by Goldman applanation tonometry. Right eye 18 millimeter mercury, left eye it's 40 millimeter mercury. And gonioscopy done with Goldman 2-mirror gonioscope. Right eye it's all open angle, left eye all open angle with there is a peripheral anterior synecdoche in the supero temporal quadrant and also in the didn't mention here but drawn here.
But clock hours?
Just 2 clock hours, extending 2 clock hours.
Total altogether is only 2 clock hours.
A total total 8 clock hours, but patchy peripheral anterior synecdoche. Total 8 clock hours is there.
So what is the significance? IOP is only 14 also. With so much peripheral anterior synecdoche. What could be the reason? Again,
this peripheral anterior synecdoche may be due to intraocular surgery.
No, I'm asking why with extensive PAS, the IOP is very, compared with the other eye, it is low. It is only 14. What could be the reason?
Rhegmatogenous.
Yeah, maybe what Sir said, rhegmatogenous retinal detachment can produce a low IOP.
How are the?
There is discrepancy between a production and
no. Why in rhegmatogenous retinal detachment intraocular pressure is low usually?
so production
Production is going on.
But absorption.
The uveoscleral outflow will be more, no, because there is bare choroid. Understand? Then in severe proliferative retinopathy like this stiff retina and all, there could be ciliary body detachment also. That also causes hypotony. So these are two things that is possible in this case. There is a big break. When there is a big break, the fluid will drain, UV scleral outflow will be more. Right.
8 clock hours, you could make out all the open angles in between.
Yes, ma'am. Only at the site of PAS, the balance is 3 visible.
Rest, you can see the open angles.
In that area, there is no
On
neovascularization.
vascularization angle in left eye.
And also iris, there is no neovascularization.
Vascularization.
Is there any ectropia?
No, ma'am.
Okay, continue.
Right eye diagnosis, probable diagnosis, right eye, nodular sebaceous gland carcinoma involving meibomian gland. Left eye, so it was my previous diagnosis. It was all combined fractional rhegmatogenous RD, but now all the rhegmatogenous RD, status post vitrectomy and silicone oil implantation and followed by removal and aphakia.
Okay, Ardi, I just wanted to ask you some questions. You have put to the diagnosis as nodular sebaceous gland carcinoma, right?
Yes, ma'am.
Okay, from the history, what are the findings in favor and against?
First is age, elderly patient, and it's common in
Elderly, you have to say the elderly male or female? Huh?
Male patient actually. It's,
Yeah.
not favoring for sebaceous. Sebaceous gland carcinoma is actually more in female, but in this case, male.
Yeah.
But elderly patient
Mhm.
and most common malignancy of eyelid in Asian.
Okay.
So that's also favorable. And the site is upper eyelid
Mhm.
and its size.
Why upper eyelid is more common, sebaceous gland?
More meibomian gland in the upper eyelid.
Yeah, what's the number of meibomian glands? I think I should ask others also. Dr. Alicia, what's the number of meibomian glands in the upper eyelid? She said it is more common in upper eyelid because meibomian glands are more common in upper eyelid. What's the number? I mean, anybody, it's a quiz question also, whatever it is. Are there any wild guess?
20 to 30.
Sorry, 15 upper eyelid, 25 lower eyelid. It's very easy to remember. Okay, yeah. Then second, third.
And these sebaceous gland carcinoma develop only from these meibomian glands?
No, ma'am. Also from C's gland and also from the sebaceous glands of caruncle and also from eyebrow.
Not
And develop
eyebrow.
from the Z.
Hairs,
No, it is from the C's glands.
C's gland and caruncle.
The history, there is no rapid increase in size, right?
No, ma'am. No
Okay.
rapid increase in size.
No watering, no irritation, nothing.
These are unfavorable.
Yeah, there is no ulceration, no bleeding.
No lashes, loss of lashes, no rounding.
That's a clinical examination. Yeah. So the history wise,
There is no rapid increase in size.
yeah,
No.
only the age in favor, to be frank.
Yes.
Right? Yeah. Okay. From the clinical examination point,
First, upper eyelid swelling is large and it is firm to hard in consistency. And the palpebral side, there is a yellowish discoloration.
can you put the picture again? Is it yellow? Or is it some kind of
It's like dirty white, more towards yellow side, ma'am. Not
yeah, so
Somewhat
Wait.
purple now.
yeah, it is like dirty white or something. Yeah. But anyway, definitely doesn't look yellow.
I think more on the skin surface there was some
Yes, yellowish.
sebaceous condition.
Then you can highlight each point. Is there any loss of lashes?
no, ma'am.
No. Okay. Then what about the meibomian gland orifices?
No distortion in orifices.
Mm. By the way, why loss of lashes occurs in meibomian gland carcinoma? What's the reason for loss of lashes?
Thickening of anterior marginal hair follicle.
Harsha can tell she's senior.
Invasion,
Yeah.
invasion into hair follicle.
Yeah, it is invasion or infiltration of the tumor cells of the hair follicles. Okay, fine. Then why yellow color in sebaceous gland, Harsha?
Due to high lipid content.
Yeah, sebum, yeah, high lipid content. Okay. So now we are looking at the meibomian gland orifices. So what's is it abnormal, normal in this case?
It's normal.
Yeah, it looks normal even from the picture. Yeah. Then meibomian glands are located in tarsus. So what's the thickness of tarsus in this case?
It's also normal. Thickening of.
Yeah. Okay. Then any other findings? You said mechanical ptosis, no?
Yes, ma'am.
Why it is mechanical? Like what is Celsius action?
Due to the gravitational effect of the large size of tumor, causes mechanical ptosis.
What are the other reasons for ptosis in this case if it is sebaceous gland?
Can invade into the muscle.
So one is infiltration of the muscle. Second is mechanical, as you said. Okay. Then, so from the clinical examination, there is no loss of lashes. Meibomian gland orifices are normal. Color is little suspicious. Okay. Tarsus looks more or less normal, right?
Harsha, with the other eye having no vision, patient having a mechanical ptosis of this much, is a head posture normal? Patient doesn't have any vision in the other eye. And because the picture shows a mechanical ptosis almost covering half of the way. Patient should have a head posture for that, no?
In elevation should be much in elevation.
So the blurring of vision can also be because of the mechanical ptosis.
Any other diagnosis? So
Yeah.
Marian Madam was asking the points in favor. So only one point you said, that is meibomian gland carcinoma, sebaceous gland carcinoma in favor is the size and upper lip. Any other points in favor for a sebaceous gland carcinoma other than these two?
Consistency.
Consistency, and is there any dilated vessels?
Dilated vessels over the swelling.
But conjunctival aspect looks normal. Only the skin aspect shows vessels, isn't it?
Yes, ma'am.
Yeah, okay.
Do you have any differential diagnosis in this case? One is first is sebaceous gland. Any other differentials?
Benign tumors.
That is a non-specific terminology. There are so many benign tumors.
Why not other malignant tumors?
Yes.
Yes, ma'am. Malignant tumor, basal cell carcinoma, and squamous cell carcinoma are the two close differential diagnosis for sebaceous gland. But
What is the usual presentation in these?
basal cell carcinoma most basal cell and squamous cell carcinoma most commonly affects lower lid, and basal cell carcinoma will have pearly rolled out edges, but most of them having ulcer in the center.
So in this case, it's mainly a nodular swelling and in the upper lip also. That's why you go more in favor of a sebaceous gland, even if you think as a malignancy, malignant swelling.
Any other benign tumors
Benign.
you mentioned? What other benign tumor?
Sebaceous gland adenoma can also present like this.
Adenoma, is it very common?
No.
Okay.
Common
So,
things.
some common things, yeah.
Chalazion,
Yes. Yeah. So how will you differentiate? Is it a chalazion? Why? If it is yes, you tell me the no. Is it chalazion?
it's painless. There is a gradual increase in size and upper lid. That's also more common. And then There is no loss of eyelashes and there is no ulceration.
See, chalazion, usually when you invert, you have some signs of inflammation.
Right.
Here, when you invert, there is
Fiber.
no, yeah,
There is
no inflammation.
chalazion.
Then history also, patient usually gives some history of lid edema or some pain. Yeah.
Initially.
Any other?
Other
Any other
Harsha.
differentials? Yeah.
Harsha. Alicia.
sebaceous cyst.
Sebaceous we have already told. Any other differential diagnosis? There are some cystic lesions, no?
Epidermal system.
Epidermal cyst. How it presents?
Cystic swelling will be cystic in consistency. That is
Yeah.
means
Age
it is
group,
firm to hard in consistency.
age.
Age also middle age, younger.
Above 40s. Like, yeah. Cystic, then findings on the tarsal surface.
So I don't know.
What are the findings on the tarsal surface in the case of tarsal cyst?
Tarsal cyst there will be large inflammation.
You can have thinning of the tarsus. The cyst is in the tarsus, so this mechanical thinning can cause. I mean, you can have thinning of tarsus.
The stretching.
Then what about the skin surface in tarsal cyst? What is going to the skin? It's normal. Skin is going to be normal. So in this case, what is the skin? How is the skin?
There is only dilated veins over the skin.
Yeah. Why the dilated veins? Why the dilated veins in this?
Maybe feeder vessels if it's malignant, or any skin's large swelling can cause stretching.
Because of, see, when a mass presses over the vessel, what will happen?
Dilatation.
Yes, stasis. Okay. So now, how many differentials we are having?
First, sebaceous gland carcinoma. Other
Yes.
is squamous cell carcinoma and basal cell carcinoma.
Mhm.
Then benign lesion like
Tell
large
the type also. Nodular, basal cell.
carcinoma. Then benign lesion like large chalazion and sebaceous adenoma, which is rare, and epidermal cyst and tarsus.
Okay.
So
What is Meckel
prioritize
cell
which one?
carcinoma?
What ma'am? Sorry ma'am.
Meckel cell. That also will.
It's rapid growth.
That also has a loose skin over it. There will not be any skin because that arises from the dermis. So that can also present with the skin on the surface will be normal. That also more common in the upper eyelid, but it's a very rare.
Okay.
So when you categorize it, which comes first in the differential diagnosis? If you revise the findings, favorable points, which will come in first as a differential diagnosis. After sebaceous gland carcinoma, it should be a tarsal cyst. Because it's a tarsal cyst usually can become so large. Chalazion, usually it is not that large compared to a tarsal cyst. So you can tell now how will you proceed with the right eye? And we have a discussion, separate discussion, right eye and left eye, two different things.
Loss of eyelash. There is no loss of eyelashes. That is also against definitely against a malignant condition, because in most of the malignant condition, you can have loss of eyelashes. Then rounding of the posterior lid margin. All these are the signs of malignancy you should look for. Telangiectasia, thick vessels, ulceration.
Okay,
None of these findings are in this case.
Ardi, you can proceed. How will you investigate the patient?
First, this or biopsy should be taken. In this case, incisional or excisional biopsy can be done. And according to the report, we can plan surgical resection. The main treatment is surgical resection. Even before, we can do pre-op investigations like blood routine, blood sugar, and also like routine investigations.
So you said incisional or excisional. I mean, you have to say something like either incisional or excisional. What? In this case, what will you do?
Excisional
And why? Okay.
Excisional, excisional biopsy with
excisional biopsy. How? Like which approach?
Most
micrographic surgery. Okay, fine. It's a good idea, but I don't think anybody is doing in India.
With the frozen section, ideally with the frozen section.
So in this case, when we are in a little diagnostic dilemma, okay, so we can do an excisional biopsy under frozen section. Frozen section will give a diagnosis. Okay, diagnosis also.
And then proceed with the mutilating surgery, because the patient is one night. That is a very important thing in this patient, because the other eye has got a...
It's a large swelling also.
Yeah. So if we proceed with... Okay, so that is the importance of doing frozen section. And
positive for tumor, we should clear around 5 millimeter lid margin, and up to negative tumor negative, we should clear the tumor, and then lid reconstruction. It's frozen section, we can ideally do say at the same sitting. So for this much large.
What is the histopathological appearance in a sebaceous gland carcinoma?
It is a hyperchromatic nuclear with large vacuolated cytoplasm because of the lipid.
Any special stain for the lipid?
Sudan and oil red of milk.
And histopathology, they are specifically saying, I don't know about peripheral palisading. Marian madam may be knowing more about that.
So in this case, you are planning excisional biopsy under frozen section. Okay, suppose excisional biopsy frozen result comes as sebaceous gland carcinoma. Then what will you do?
You should resect 5 millimeter.
Yeah, 5 is little more, 4 millimeter. Yeah,
around the margin.
All around.
Around the margin.
Medial, lateral, and superior.
And also, we should look for MAP biopsy. Conjunctival MAP biopsy should be taken. That is started around the lesion and also from the highly inflamed areas, around 17, including caruncle, should be taken.
But MAP biopsy is negative. Okay, MAP biopsy turns out to be negative, and this is well differentiated sebaceous gland carcinoma, margin free.
Lymph node.
Okay, then.
Node dissection. Ideally.
Sorry, don't say you are. I'm asking what you are going to do in this case. So in this case,
Madam is asking the MAP biopsy is negative, only the frozen section of the swelling is positive. How will you proceed?
So that means limited to the lid lesion alone.
Yeah.
Reconstruction, we can plan lid reconstruction.
That is a vague terminology. How will you reconstruct?
So you said it is a 15 millimeter swelling, 15 into 15 millimeter swelling.
Either side, so it's around 15 plus 9, it's around 24 millimeters. So it's a large, large lid defect. So ideally for the large upper lid defect, we do lid sharing procedure, that is Cutler beard procedure. But we should consider this patient's other eye, that is PL plus, and so will take around 6 weeks for the complete. I mean, that will be for the resection of the.
No, so in this case, other eye is only PL, no? So how can you keep the patient blind for 6 weeks?
So
lid sharing is not an ideal procedure in this case. So what are the other options in this case?
Pencil flap can be.
Okay, if the lid is very loose, you can stretch, you can try tensile, but other than that.
Cheek flap.
Cheek flap is for whom?
Upper lid, it's in the upper lid.
It is in the upper lid.
So lid
Any other flap?
reconstruction, don't mug up.
Glabellar flap.
No. See, lid reconstruction, don't mug up. We need one anterior lamella and we need one posterior lamella. Okay. So we have got a large defect in the right upper lid. Lid sharing is very difficult because patient is other eye blind. So from where will you get posterior lamella in this case?
Posterior can be done at the contralateral tarsus.
Yes. So you can take a free tarsal graft
From the
other eye. Okay. So that is one option. Free tarsal graft for the posterior lamella and anterior lamella from
skin, either skin graft or
you can advance. You can advance the rest of the skin anteriorly.
or oral mucous membrane palate or tarsal, then
Sorry.
hard palate, tarsal.
Yeah, hard palate in upper lid, it can irritate the, ocular surface. So usually for lower lid, we can use hard palate, but upper lid, hard palate should be very careful, and that too in this case. Okay. So one is pre-tarsal graft. Second, see, 24 millimeter is the defect. So little bit of tarsus on both sides remaining. So you can slide a sliding tarsoconjunctival flap. That also can be done for the posterior lamella. Okay. Yeah. So either of those can be done in this case. Okay. Here, what's the size of the lesion?
15 into 15 millimeter.
Okay, if it is a sebaceous gland carcinoma, what are the poor prognostic factors in sebaceous gland carcinoma? And if this case belongs to the good prognosis or poor prognosis?
Bad prognosis.
Okay.
More than 10 millimeter in size and upper lid involvement, and the duration is more than around 6 months. That's also poor prognostic factor. Others are lymphatic inversion or bitic inversion or hematogenous spread. Then
Pathology?
Poor differentiated tumor.
Yes. So poor differentiation, size more than 10 millimeters, angiolymphatic invasion, then orbital invasion, and these are the main poor prognostic factors. So in this case, what else would you like to do? Because the size is 15 millimeter in this case. You said there is no lymph nodes palpable. So what extra thing would you like to do?
Ma'am, sentinel lymph node biopsy.
Yeah, good. So we would like to do a sentinel lymph node biopsy also in this case.
Then
Suppose, and also
for the metastatic lesions, most common liver or lungs, distal metastasis. So we should order CT chest and abdomen also can be done to rule out distal metastasis.
Okay. So suppose sentinel lymph node is positive. Then how will you proceed further?
That lymph node, the positive lymph node should be dissected. Along with radical neck dissection. If it's cervical lymph nodes, radical neck dissection advised.
Okay, fine. So in this case, we reconstructed with the pre-tarsal graft for the posterior lamella and sliding muscle flap for the anterior lamella. And how will you follow up the patient now? You cannot send the patient go home and come after some time. No, you cannot say review SOS. You cannot write review SOS, obviously. So how will you follow up in this case for the right time?
To the right side, you should look for this metastasis frequently.
No, I'm just asking you, your whole wound is healed and the reconstruction is fine. Margins are negative. Sentinel lymph node is negative. Now, how will you follow? When will you call the patient?
How long or how intermittent, how
Yes.
frequent? Monthly, 2 monthly, 3 monthly, like that. How long you should follow up the patient? Can it be the recurrence?
2 monthly, ma'am.
3 months. 3 monthly for 1 year. For first 2 years, follow up every 3 months, and then 6 monthly for up to 5 years, and then yearly thereafter. That's the ideal way to follow up a poor prognostic sebaceous gland carcinoma. Okay, suppose the frozen section is negative for sebaceous gland carcinoma. Then
So that by excision is enough. There is no need to continue the 5 millimeter around the margin.
and you can directly close.
So the
Okay.
When will you directly close the lid? How much defect you can directly close?
small defects,
Small means
less
involvement.
than
Less than
8%
1%.
involvement,
Less than 33%.
involvement of liver.
Okay, suppose if the mark biopsy shows positive for the Pagetor spread, then what extra will you do?
Excision should be done for all the procedure. If there is orbital,
Sorry. You are taking 17 mark biopsies, right?
Yes, ma'am.
17.
Positive,
Uh,
positive
for-
is accepted.
Positive?
Remember, the patient is one eye.
Yes.
Additional radiotherapy,
Radiotherapy? Do you
chemotherapy,
think
Or
sebaceous
sebaceous
gland?
gland.
chemotherapy can be
Tell me.
mitomycin or imiquimod.
You can give mitomycin. You can give topical mitomycin C. How will you give?
0.02%.
0.4%. How many times?
How many times a day? How many days a week? And
2 weeks
How many weeks?
QID daily for 2 weeks, then weekly.
There are so many methods. Like either you can give 1 week, then 1 week off, like that, 6 cycles. What precaution will you take? He's one night. What precaution will you take in this case? In other words, what are the complications of topical mitomycin? Sorry? Limbal stem cell deficiency can occur. So you should closely watch. Then you have to tell the, you have to advise punctal occlusion when you give mitomycin C. These are 2 important things. Or you can keep collagen plugs in the punctum. Okay. Dr. Mallika, Dr. Dalia, anything would you like to add?
okay, is there any role for 5FU?
No, ma'am. It's actually other malignant tumor. Sebaceous gland carcinoma, it's ideally mitomycin C.
Okay, what about the other eye? What will you do? Anything to do with the other eye? Anything to offer?
I think this eye also testing corneal sensation is important. Why?
No. Trigen.
Yeah, trigeminal nerve involvement can also occur. So corneal sensation should also be checked.
What about the other eye, Ardi? Anything to do?
In terms of oculoplasty, ma'am?
No, other eye.
Other eye.
I am asking about the other eye.
Are they having any oculoplastic problem?
Rhegmatogenous, it's rhegmatogenous retinal, old rhegmatogenous retinal detachment, status post vitrectomy and silicone oil removal, and it's PL plus. So,
PL
How
plus
do you know it is silicone oil removal done?
just from history, ma'am, sir. Nothing.
Huh? History.
From history.
No, suppose his silicone oil was put, there will be one finding in this case, which
patient
you
is
have not
aphakia.
mentioned. What is it? There will be one finding. If anybody puts a silicone oil, there is another finding in the anterior segment in slit lamp examination. You didn't mention that.
Patient is having aphakia also.
Yeah, when there is aphakia, more problem. So when there is aphakia, when somebody is putting silicone oil, there is a very specific finding that you have to tell. That was not there here.
You mentioned about PAS, but
Verse hypopyon.
Silicone oil is push.
Huh?
no,
Verse
in the
hypopyon.
iris. Inverse hypopyon is a complication. Sir is asking some procedure must have been done. while
Peripheral
doing-
iridotomy.
What
type
peripheral
of-
iridotomy?
Inferior.
Inferior iridotomy, andos iridotomy, it is called a lot of names. If somebody is putting silicone oil in an aphakic eye, you have to do an inferior PI, peripheral iridotomy. That was not there here. So we are not sure whether oil was put initially, right? Anyway, currently that all that white things are all due to PVR, bad PVR, and retina is very stiff. So there is no potential. What could have been the cause for retinal detachment?
Sir,
in
What
this
could have been the cause for retinal detachment?
in terms of branch
Cause.
vascularization,
Ah.
either vascularization, which is secondary to any vascular occlusion, which
Secondary to vascular occlusion, what other finding will be there? There will be all sclerosed vessel, no? There is, you didn't see anything. Is there any sclerosed vessel?
so it's all elevated. So couldn't make out sclerosis.
Then how come that vascular occlusion came to your mind? When I see something like this, I thought I will think always it was an old retinal detachment surgery which has not worked. I mean, not able to attach the retina. Old recombinant RD. So why think about retinal vein occlusion in this case?
Posterior vitreous detachment, PVD.
No, PVD and all, that is cause. I am just telling what could have been the etiology. When I see this, I thought it was an old recombinant retinal detachment surgery, post-surgery. There is nothing to suggest that it was a vein occlusion. No?
Only from the patient's history,
So,
patient is
yeah.
saying some blood in the eyes.
Blood you can get in PVD also. I will see, we should use common sense very routinely, not taken away by some words that patients say. It would have been a retinal detachment that failed. So anyway, currently it is difficult. When oil you're mentioning, you should tell whether there is inferior PA or not, especially in aphakic. Nothing more in the left eye, because there is no need to go on extrapolating. This would have been that, this would have been this, and then discuss that topic. No.
Are the
And what
patient
could be
was
the
telling
reason
of
for
a
failure?
slow onset,
No, failure
insidious
also.
defective vision in the left eye.
Insidious defective vision can be. Then why should we think
that
about retinal vein occlusion? Insidious defective vision can be anything, no?
I was just asking Aradi.
Can
Rhegmatogenous RD can slow onset. Why did the patient present like that?
It's in case of inferior break.
Inferior break, you can get insidious. Then initially there will be vitreous hemorrhage, and then due to PVD, bridging vessel, it can bleed. Then once the blood clears, there will be RD. All these are possible, very commonly possible things.
And you can see the PVR changes also. That may be the reason for failure of RD surgery.
Yeah.
Only thing is from patient's history, he is saying silicone oil is implanted and oil has removed also. 2 surgeries he underwent, isn't it? According to his statement.
That even in recommended retinal detachment or vascular occlusion detachment, anything you can, everywhere we put oil, any of the detachment, there is no difference. Usually in vascular occlusion, if the surgery is not successful, usually they will go into neovascular glaucoma, usually.
Here there is no, but extensive PAS is there,
Yeah, yeah.
but no NBIC.
NVA.
Okay, so this PVR may be cause for a failure. No? Causes of failure of fragmentogenous retinal detachment, surgery. What are the causes? What are the causes of failure of fragmentogenous
Missed
RD
break,
surgery? Ah, yeah.
missed break, or positioning of missed break, or then PVR, proliferative retinopathy, which can reopen the breaks, and improper position.
Its surgery positioning is needed.
It is external scleral buckling.
Scleral buckling need positioning. Missing breaks, PVR, and other causes. Failure of RD surgery. Alicia.
Resurgery. Inadequate size of the scleral buckle, fish mouthing of the scleral
But
buckle.
this patient, there is no scleral buckle. There was not a scleral buckle surgery. Development of new breaks. Maybe development of new breaks. Anything to discuss, Mahesh?
Nothing, because nothing relevant in this case.
And nothing to do for also left eye
Yeah,
for getting
yeah.
vision. And it is painless also. The eye is not having any pain. So you can just leave the left eye and you have to focus on the right eye.
Prognosis is poor. So better to leave.
There is no point for any resurgery in the left eye. It is a painless blind eye. So nothing to do, offer for the left eye. Only the right eye. Okay.
Hardik, how will you differentiate this blepharitis type of agitoid spread of malignancy and blepharitis? Whether it presents as a blepharitis, can present like. How will you differentiate? What helps you to differentiate? Especially the sebaceous gland carcinoma.
Conventional treatment can cure this blepharitis.
Unless it is resistant to treatment, then loss of lashes will be very particularly seen if it is a malignancy. And if you palpate, you will see more thickening, rather more than the amount you inspect. When you palpate, you will have a more thickening of the tarsus plate. So all these will help you to differentiate.
One which is usually this
And this unilateral.
unilateral, yeah.
What type of blepharitis? Differential comes as a differential diagnosis.
Mainly chronic and ulcerative blepharitis.
Ulcerative type of blepharitis. Marian, anything else to discuss?
Yeah, I just wanted to ask you, Ariti, there is no proptosis in this case, no? Okay, if there is proptosis, then what is, how will you manage? How will you proceed in this case?
There can be orbital inversion. So,
yeah, we are suspecting orbital invasion. So, how will you proceed then?
Orbital excentricity.
Amma, how will you confirm orbital?
MRI. Sorry.
Making the patient blind, totally blind.
Imaging should be done. That is
like they were telling right check head, otherwise PL.
Sorry, ma'am.
Otherwise, no PL, just PL, PR inaccurate.
Yeah, MRI should be done.
Yeah, MRI to look for
soft tissue involvement and extension of orbital involvement.
We know the posterior extent and the structures involved, whether sclera is involved then extraocular muscles. Suppose MRI shows, MRI confirms the orbital involvement. So what you can do in this case?
Considering the other eye, you should directly not go for excentration, either systemic chemotherapy, external beam.
So you are telling everything, external beam, radiotherapy, which one? You go for neoadjuvant chemotherapy. You will go for chemotherapy. Okay, which drugs? Anybody?
Cisplatin and 5-fluorouracil.
Yes, 5-fluorouracil cisplatin. Usually, it will go for tumor reduction, and you can, after the 3 cycles, you can excise only the lid lesion. Okay, and you can continue the chemo post excision most of the times, because his one night we have excentration is, we are not thinking in terms of excentration at all. Okay. How will you manage liver or lung metastasis in this case? Is there any treatment?
Chemotherapy.
Huh? Yeah, it's just palliative chemotherapy only.
Which malignancy most commonly produces systemic spread?
Most commonly sebaceous gland carcinoma, or then squamous cell carcinoma also can produce distant metastasis.
Basal cell is actually locally invasive. That is the most important thing. There is no distant spread, and local spread is also very rare. So orbital extension is common in which type of sebaceous gland carcinoma? Carcinoma from which site? Sebaceous carangle, from the carangle. If it occurs, even though it is a very rare presentation of a meibomian gland carcinoma, or not meibomian gland, sebaceous gland carcinoma, rare presentation is from the carangle, and which has got a high chance for orbital invasion. And the CS gland has got the best prognosis, but differentiation is very difficult, arising from meibomian gland or CS gland, because both presents as lid tumors. Okay, Marian, anything else to discuss?
I think we have covered almost everything.
Okay, sir. So I think we can stop. Gopal, Rehana?
Yes, Rehana.
That was very nice case discussion. It was a confident and beautiful case description by Dr. Arati. And the case discussion was very systematic, starting from the positives and negative history and examination to include or exclude the differential diagnosis, the surgery, the reconstruction. It was very systematic. Thank you very much, Mallika ma'am, Dr. Dalia, Dr. Marian, and Mahesh sir for that wonderful discussion. I'm sure that the postgraduates will find it really very useful. Thanks a lot. And next week, we'll be having again the second round of corneal topography investigation discussion by the same team.